Therefore, bringing these principles together in terms of the pretest probability, as well as how we utilize the D-dimer in the workup of patients of DVT, we start first by having a clinical suspicion for the patient having a DVT, and we then determine the pretest probability using the Wells score. If they have a modified Wells score that is less than or equal to 1, then that patient has a low pretest probability, in which case we order a D-dimer. If that D-dimer is low, meaning less than 500, then we do not pursue any additional testing for DVT. If that D-dimer, however, is high, then we are going to need to get a compression ultrasound. Additionally, for patients who have a high pretest probability with a modified Wells that is at least 2, then those patients are also going to get a compression ultrasound. Therefore, there are two potential pathways to getting a compression ultrasound of the leg. One is having a low pretest probability, but having a high D-dimer, which ultimately points us in this direction. Or if we simply have a high pretest probability to begin with, then we should also get a compression ultrasound. In actual clinical practice, this can be a bit more nuanced, but for examination purposes, this is really the best way for us to approach these questions. Once we get our compression ultrasound, if that ultrasound is negative, then the DVT is highly unlikely, and if that ultrasound is positive, then we can consider giving anticoagulation therapy. Here we have an example of a compression ultrasound of the deep veins of the leg. In particular, this is the left common femoral vein of this particular patient, and normally we would expect that this vein would be patent. However, as we can see here, there is clearly the presence of this clot here, and this is highly characteristic of what we would see on ultrasound in a patient with a DVT. As we will discuss in more detail in our modules on pulmonary embolisms, the emboli which ultimately cause a PE usually originate in the deep veins of the leg. In particular, however, these most commonly come from the femoral veins, in other words, the veins that lie above the popliteal vein of the leg. And therefore, in our discussion of the veins of the leg, and therefore in our management of patients with DVT, it is important here to distinguish those veins which lie above the popliteal vein and those which lie below the popliteal vein. And as we will see in a moment, this distinction in terms of those veins that lie above the knee and below the knee can make a significant difference in terms of our management and whether we decide to anticoagulate our particular patient. Based on this convention, we can divide our DVTs into those that are proximal DVTs and those that are distal DVTs. Our proximal DVTs include those which originate in the popliteal vein, the femoral vein, and the iliac vein, essentially anything that is at the level of the popliteal vein or above. It should be noted that 90% of pulmonary emboli originate from the proximal veins of the leg. And this is why, unless these patients have an absolute contraindication to anticoagulation, then we should really be anticoagulating all patients who have these proximal DVTs. This, however, is not the case for our patients with distal DVTs, including those which involve the posterior tibial vein, the peroneal veins, or the anterior tibial vein. In other words, the veins of the leg that are below the level of the popliteal. This is because DVTs from these more distal veins are less likely to become pulmonary emboli. And therefore, when it comes to distal DVTs, we are only going to give anticoagulation in select patients. Overall, the hallmark of management in our patients with DVTs is going to be anticoagulation. However, the real key is determining whether or not to give anticoagulation depending on the particular patient. For those patients in which we have suspicion for a pulmonary embolus, then we should really start anticoagulation therapy immediately for these patients. Additionally, for those who have a proximal DVT, the risk of them going on to develop a PE is so high that unless they have an absolute contraindication to anticoagulation, we should give anticoagulation for all of these patients. In contrast, when it comes to those distal DVTs, meaning those which are originating below the level of the popliteal vein, we are only going to give anticoagulation in select cases, particularly in those patients who are symptomatic and who also have a low risk of bleeding. And when it comes to anticoagulation therapy, we have multiple options at our disposal. We can give heparin and ultimately bridge to warfarin. And we could also utilize our DOACs and NOACs, including rivaroxaban, as well as apixaban, which will not require that heparin bridge. And as is often the case in actual clinical practice, when it comes to the use of anticoagulation, we are really always trying to balance this risk between the development of emboli, in this case pulmonary emboli, and the risk of bleeding. And therefore, while we are keeping it pretty cut and dry for the purposes of answering questions on examinations, just realize that in actual clinical practice, this is often going to be a lengthy discussion with a consideration of multiple factors in determining whether or not to anticoagulate your particular patient. One important modality that we have at our disposal in patients who have an absolute contraindication to anticoagulation therapy is the use of inferior vena cava or IVC filters. These are not routinely used in patients with acute DVT and instead are reserved for patients who have the following three characteristics. The patient must have an acute proximal DVT, and note here how I am emphasizing proximal because these have the greatest risk of going on to develop pulmonary emboli. The patient must also have a pulmonary embolism, and last but not least, the patient must have an absolute contraindication to anticoagulation therapy. These absolute contraindications include having a recent surgery, as we should not be giving anticoagulation in patients who have recently had an operation, patients who have had a hemorrhagic stroke, as this can increase the risk of them bleeding more, and in patients who have other active bleeds, such as GI bleeds. Therefore, the IVC filter can be extremely helpful in patients who have these high-risk proximal DVTs, who already have a PE, and who have one of these absolute contraindications to anticoagulation therapy. Here we have included a brief summary highlighting some of the key high-yield points that we should know for our examinations when it comes to DVTs. However, based on my experiences working with students, really understanding how to use the modified Wells criteria and determining when to get a D-dimer and when to get a compression ultrasound is probably the most high yield out of anything we have discussed in this series. Therefore, I would just like to bring up this simplified algorithm one last time that you can utilize when determining whether to get a D-dimer, when to give a compression ultrasound, and ultimately when to move towards anticoagulation therapy or the use of an IVC filter in patients who have an absolute contraindication. This is Boards MD, and this is DVT.